Okay, so good afternoon to our speakers and audience. Thank you for joining this webinar on personalized anesthesia, aiming for precision. My name is Rachel Weisbrod. I lead clinical activities at Medicines Biometrics. I'm delighted to introduce our speakers today, who will be educating us all on what personalized anesthesia is to them, why it is important for patient outcomes, and how, most importantly, they go about implementing it in daily clinical practice. Dan Longrois is a professor of anesthesia and intensive care from Bichat Hospital in Paris, France. Thank you for joining us. Dan is a recognized expert in monitoring and pharmacology and their interface with anesthesia, intensive care, and perioperative medicine. Dr. Finn Radtke is head of research at the Department of Anesthesia and Intensive Care at Nykøbing Hospital in Denmark. He's also the founder of the Safe Brain Initiative that focuses on improving anesthesia-related patient outcomes through providing practical tools and educations for the clinical community. We'll be hearing more about this in his presentation. We'll start with a short lecture from each presenter on personalized anesthesia, incorporating both nociception and depth of anesthesia monitoring. After these two short presentations, each speaker will be presenting a clinical case, a real clinical case, demonstrating the impact of personalized anesthesia monitoring on clinical decision-making. Each speaker will then comment on the case presented by his peer. We welcome your questions too. Please use the Q&A tab or the chat to present your own questions as you listen to the speakers. We'll be carefully monitoring the chat and Q&A feeds, and we'll have a 10-minute Q&A session at the end, at which we will address your questions to the speakers. So without further ado, Professor Longrois, over to you.
Thank you very much for this very kind introduction, Rachel. I would like to tell everybody that I'm very happy to be here and that I have collaborated now for many, many years with all the major manufacturers who have an interest in monitoring the depth of anesthesia. So the goal of what I'm going to share with you is to put somehow into perspective this nociception and anti-nociception monitoring into clinical reasoning. So the goals of the presentation is just to show you that still, despite many efforts, the context is some uncertainty about what is adequate anesthesia. I'm not talking about depth of anesthesia or good anesthesia for a given patient at any time. And therefore, we should attempt, and this is what I will do, to put in parallel the scientific approach of nociception and anti-nociception balance monitors, and share with you what could be the decision tools on which you decide, and we decide that we give hypnotics, we give opioids, we give the two of them, or how we actually put the information that the monitors provide for us into decision making. So just to be sure that we share the same definitions, during general anesthesia, the term pain should probably not be properly used because there's no conscious and sociocultural component during general anesthesia, which are elements of pain. So nociception is the neural process of encoding noxious stimuli, and this encoding would actually cause autonomic and or behavioral responses, such as elevation of blood pressure or motor withdrawal reflexes for patients who do not receive neuromuscular blocking agents. And I personally still am asking myself whether this encoding of nociception is related to a change in the level of nociception or to a constant level. And it is my impression, but I cannot guarantee that I am right, is that what the body perceives and the way it encodes nociception is the change in the level of nociception. So when the nociception and anti-nociception, that is opioids, for instance, but not only opioids, are balanced, there's lack of encoding. And therefore, there's a lack of autonomic or behavioral responses. So the nociception and anti-nociception balance monitors are supposed to detect an imbalance between nociception and anti-nociception much better, that is with a high specificity, high sensitivity than to changes in heart rate map and even the EEG. So just to actually attempt to convince you that this becomes not only a fancy or research-oriented area, but it's becoming a clinical now concern, is that there are already review articles looking at a number of monitors that are on the market. And as you can see listed there here, most of the manufacturers have actually come with proposals for this nociception, anti-nociception monitors, including the NOL from Medisense. And you can see here the index that are proposed, and eventually the range of values are targeted and considered to be representative of balanced nociception, anti-nociception. Now, what I think is, after having worked with many of them, what I think is peculiar with NOL is the fact they have gone from the beginning into a multi-dimensional signals that are gathered into this NOL index. And this is the temperature, the galvanic skin response, accelerometry. Of course, there's photoplethysmography, and which looks at the pulse rate, at the pulse rate variability, the amplitude of the photoplethysmographic. And therefore, this is possibly one of the explanations why in the literature, in terms of sensitivity and specificity, it appears that the NOL, as compared to other nociception, anti-nociception monitors, actually has better specificity and better sensitivity. And I think in my interpretation, this is related to the strategy they chose to have the multimodality. Now, there's actually convincing evidence now in the literature. First, that the NOL is more sensitive and more specific than heart rate and MAP to detect an imbalance between nociception and anti-nociception. I think there's little doubt for this. And this, you could probably take this for demonstrated, not granted, but demonstrated. Eventually, a higher sensitivity and specificity as compared to other nociception, anti-nociception balance monitors, but this is still work in progress. And there are at least a few articles which looked at outcome, and it appears that the use of NOL as compared to no NOL in prospective randomized study actually provides a better hemodynamic stability, and it also is associated with improved pain control after once the patients are emerged from general anesthesia. So I think it's there's a credible and interesting evidence that there's an improved in outcome, and you see the prestigious journals which have published these articles, and there's a very recent one in the Clinical Journal of Monitoring and Computing. So the question now is, let's quit the literature and say, how should we, as clinicians looking for a single patient at a given time, how should we interpret the information provided by the monitors, and how should we integrate this into our clinical reasoning? Basically, let's say that when I started anesthesia in the past century, I was looking at the heart rate and MAP. So I put them together. They are interrelated, but not overlapping totally. And if the patient was high heart rate and MAP was high, the patient was considered to be in shallow anesthesia, etc. Now came a few years later, the EEG. And now we have access to the processed EEG and the density spectral array, which is a new display, which is much, much more precise and much more personalized as compared to the single numerical descriptors, which are the BIS or other numerical descriptors. And in the past, let's say 5 years, the nociception, anti-nociception monitors have come to become part of the clinical practice. And now the green means that all the things that you are doing actually are in the desired zone of adequate anesthesia. And therefore, now the question is, how are you looking at those together? So heart rate, of course, are confounding hemodynamic factors, which actually explain why MAP and heart rate are not sensitive and specific to detect an unbalanced nociception, anti-nociception. You still put, and we still put all of us at the bottom of this clinical reasoning, the pharmacology. This is the bottom on which we build the whole rest. And of course, we are the only ones who can actually identify what the surgeon does and what looks as an imbalance between the nociception, anti-nociception, and at the clinical side. So all this is integrated by the anesthesiologist. Now, if you go to a multi-parameter approach, let's say that the MAP and heart rate should be within 20% of the patient's baseline, not preoperative baseline values. The processed EEG and if it's the BIS should be between 45 and 60. And for the NOL, the lower limit is drug dependent. So it's between 0 and 10, according to the drug that you're using. The upper limit is 25. So if you are in this green zone, that means that your nociception and nociception are fully balanced. Now, if everything evolved in the same direction, all those three parameters, well, you wouldn't need all three of them. You would only need one of them. The problem is that in some instances, which are fairly rare actually, but they occur, the MAP goes up, heart rate goes up, the processed EEG number goes up, and the null values goes up. So this clearly identifies a situation, I hope, exceptionally rare, where the patient doesn't receive enough hypnotics, doesn't receive enough anti-nociception, and there's a translation of this into very increased heart rate value. Now, where it becomes a little bit more complex is there are situations, and believe me, they exist, where the BIS is low, so hypnotics are in excess, and the null is above 25. So that actually illustrates the fact that you can have a defect in the anti-nociception, which is not read with the EEG, and the MAP can be within the limits, or other combinations are possible. You also have situations where the processed or the numerical EEG values go up, but the null is low, either because there's insufficient hypnotics and there's no nociceptive stimuli, or because the nociception is important, but you have given enough anti-nociceptive drugs. So this is a discordance again among the three parameters we use to define adequate anesthesia. So precision comes from the fact that with the three tools, that is of course hemodynamic as a tolerance of the anesthetic regimen, the EEG and the null, one diagnoses exactly what goes wrong according to our target, and we provide the correction which is absolutely necessary. So we wouldn't get a hypnotic for an opioid or the other way around. So this requires multi-monitoring, and there's documented evidence that there can be discordance between the two. And personalizations come from the fact that the multiple monitors allow us to adapt to the interpatient and the interpatient variability. So the take-home messages would be, I'm convinced that the nociception, anti-nociception balance monitors are here to stay. The null has a credible clinical benefit, and the credibility is building up. And the sophistication of the monitors for anesthesia adequacy is good news, because I think it will lower the level of uncertainty. And I call this a little bit more measurement and a little bit less talent. But I still insist, and Finn will also insist, I think, that pharmacology is a must in order to titrate reasonably. And the questions that I ask to myself is, how much sophistication can the frontline anesthesiologist absorb and apply in clinical practice? I think there's still place for absorbing a little bit more. And this is why we do this webinar. And probably the second question is, how long before artificial intelligence is going to help us to actually deal with so many parameters that we need to monitor and do precision and personalized anesthesia. Thank you very much for your attention. I've stopped sharing my screen.
Thank you, Dan, and great presentation. Let's move over to Finn's presentation next.
Oops. Well, first of all, Dan, thank you for a great presentation. It was very interesting to listen to, and we always learn a lot. And also thank you to Rachel for the kind presentation. So let me continue. The topic is still how to move from personalized interaction of precision, the roadway to precision anesthesia. And in this field, I will focus on how the aligning between the knowledge we have, the intraoperative manage, and align this to the real world outcomes, what we see actually afterwards in our patient in the real world. The definition of between personalized anesthesia and precision anesthesia, this is still a little bit in the making to some extent. I like very much the definition from Dan, but what I would include besides the mathematics or the physics in the personalized anesthesia approach is in precision anesthesia, it is essential to obviously to include the outcome on one side, but also the side effects of anesthesia, because all the, let's say, the causal learning effect of what the intraoperative part does to the post-operative part that needs to be included, and also to the precision adjustment to the outcomes. So two main parts in precision anesthesia is the precision delivery on one side, where we just heard a whole lot about, and the other part is precision and outcomes. Now, you could also, if you were aiming for precision anesthesia as a general field, add this with the cost effectiveness, because this becomes relevant in the real world also, and I'm sure we all agree on that one. Then as two extra part, training and sustainability, which will be both central elements in the next, at least in the next decade, with no doubt. Put this all under the umbrella of value-based healthcare, because these are all elements that will come to carry there. And then last part, if you align all these, this is kind of the scope of the Safe Brain initiative, what we are aiming for. So what are exactly the outcomes or the side effects of anesthesia that we want to avoid when we do precision care? Well, we have when you look at the ASA webpage, you can see it's nausea, vomiting, sore throat, all the usual suspects: post-operative delirium, muscle aches, itching, chills, shivering, what we would like to avoid. In the Safe Brain initiative, of course, pain everybody's concerned about, but we also include stress, anxiety, and well-being. And of course, we know that pain is not caused by the anesthesiologist, but nevertheless, it's very much in our own scope. If you now would like to make an anesthesiologist humble, and we all know that, you ask them the question, how exactly did your patient, I'm not talking about your department's patient, how did your patients in the last week, in the last month, did in regard to these outcomes? How many had nausea, vomiting? How many had high pain levels? How many had stress and anxiety? All these things. And I'm very certain that 99.9% of you will not be able to answer this question, including myself. And this is, of course, a little bit of concern, because if you do precision anesthesia and don't have the opportunity to fine-tune our precision anesthesia to how a patient doing afterwards, it is certainly a weak spot. So, especially in regard to when we apply state-of-the-art technology, state-of-the-art guideline knowledge into the perioperative process, and cannot visualize the benefits in our daily routine to that what we invested in the foresight. So special attention to certain areas in the perioperative process we can't visualize in the post-operative process, and this kind of makes it very hard to argue for higher quality if we're not even aware that we have a problem with the quality at that part. Plus, that the outcomes, how we usually monitor them, have a deficiency. Now, if you define precision outcomes, we all know that if we, for example, take pain, it's not just pain that we need to monitor, but that pain is very, very closely associated with all other outcomes. Pain in itself, but also the treatment of pain. So, for example, if you have pain, you have very commonly stress and anxiety. If you treat pain, you might have nausea and vomiting. If you have pain or treat pain, you might develop post-operative delirium. So you don't feel well, and treatment of pain also can lead to either to sedation. Non-treated pain leads to agitation. So it's very important to keep, when you monitor these outcomes and include them in your evaluation, if your treatment has been effective, you need to very much kind of keep the balance that you also can assure that over treatment of pain or will also be become visualized in your own analysis. And in the larger framework, again, all these outcomes, again, are highly influenced by how we do our sedative regimen and how we do our analgesic regimen. So if we argue for, okay, we don't need a fine-tuned sedative or analgesic management, of course, this most commonly the at fault that you don't know how your outcomes are and that you can't visualize the change in these outcomes. That's why we now in the version 3.0 developed the Safe Brain initiative, where we will be going online next week, end of next week, the third version, where we can get detailed information, first of structured assessment and detailed information on the very departmental level, how our patients fared post-operatively, but also get the detailed analysis on the individual level. So I can, for example, see only my own patients, compare them to the rest of the group to see, did that what I suppose or how I perform anesthesia, does it affect outcome, and is the quality reflected of what I do also in my patient's outcome, plus many other items, but this is one of the main items. Nobody else can see my item because, of course, we need to keep the anonymous format. And even more importantly, I can track the outcomes of all parameters also over time. So I can see if I now start using more advanced technology in regard to achieving precision or moving towards precision anesthesia, then I can see, have I been successful in this kind of this roadway into achieving these or my own goals with my patients. And we all know, and this is basically a very sad truth to some extent, that we almost always are not on the spot with our pain therapy. Either we underuse it or we overdose it. And both sides are problematic. And sometimes even in the same case, you apply your fentanyl, you overdose them at that point, and then a little bit later, the patient is underdosed again. So this is a very inherent problem of, let's say, of the intravenous pain therapy. Another part is we are really bad at monitoring outcome. This I mentioned a little bit before. This is my favorite study of Whipple. I'm just going to very briefly go through it, where you evaluate from the nurses as well as from the doctor's side and compare it to the patient's own information in regard to their pain level. As you can see, moderate to severe pain in the patient level compared to nurse and doctors, we are really bad at monitoring pain if you don't use a very strict systematic in reporting this. And a bit of, let's say, information from the real world. I'm actually noticing I'm being very negative here. But from the real world information, this is from TJ Gent, fantastic study, survey, 300 patients post-operatively, asking them how did they do in regard to pain in the post-operative setting. And again, 300 patients, from these 300 patients, 86% of the patient reported that they pain in the immediate to post-surgical period. This might be different in scenarios, but the very general principle is true. Pain is not really that well taken care of in our hospital settings. Then 75% of these patients had moderate to extreme post-operative pain. And in line with that, 88% received analgesic or medication. And from these, 80% experienced adverse effects. And these are continued pain, nausea, vomiting, and all kind of other side effects that we do not want to have or do not want to see in our patients group. So how can we do better? And that helps obviously to take a look at the literature in regard to that. Now, how can we optimize intraoperative opioid use, nociception, and pain? And two questions. One, does nociceptive monitoring optimize opioid use? And the other question I would like to answer in my few remaining minutes, does nociceptive monitoring lead to improved postoperative pain scores? So does it reduce or optimize opioid use? And does it have an effect in the postoperative setting? And let me start with the study from Myers, from Albert de Haan's group from Leiden. And here we have the question, does NOL-guided analgesia reduce opioid consumption? We can see it's a randomized controlled trial, standard care versus NOL-guided care, 80 ASA 1 to 3 physical status patients. And what they found, again, randomized controlled trial, yes, obviously they could reduce the remifentanil administration by 30%, and very much in line following the logic. They had less hypotensive events, highly important. We just heard that Dan was talking about, Professor Longrois was talking about that, that he very much aims for the 20% threshold in regard to blood pressure management. And again, we also can see that this is in line that the antihypotensive medications were also reduced in the NOL group. Another study in regard to does also the nociceptive monitoring lead to postoperative pain? Again, from Fleur Myers, from Albert de Haan's group. This is a year later, now published in BGA. The other one was published in Anesthesiology. And here we have a two-center study, 50 patients, abdominal surgery, NOL-guided fentanyl dosing versus standard care. And also very interesting here in regard to the one-time proven that or shown that we can save the opioids, and now this time shown that this also can that also relates to a reduction in post-operative median pain levels. And the interesting part, again, if you look at this 3.2 versus 4.8, this is exactly the area where it makes a difference. In one part, you would intervene with pain medication, and the other part, you would not intervene with pain medication. And then the last study published this year in Journal of Clinical Monitoring and Computing from Fuika. And this is the study I actually like the most, to be honest, because this kind of reflects how my own, how I like to proceed myself with nociceptive monitoring. And here they have one group where they have the null intervention, and then they have the standard care group. And in the null intervention group, they defined to their fentanyl or the pain administration according to if the patient was longer than 1 minute above the threshold of 25 on the null monitor, then they received analgesic intervention. If not, they did not receive analgesic intervention. So this is pretty much how I or our team does it in our clinical routine. And what they found, again, median pain score after 90 minutes was, the median pain score was 3 in the null group and 5 on NRS scale in the standard care group. And what makes it interesting, this is what they displayed kind of graphically. In the standard of care group, you had much more severe pain, you had more moderate pain, and you in the milder pain group, of course, this was a little bit reversed. And what I personally, from the Safe Brain Initiative perspective, like that the RAS level, the level of sedation, so the side effect of adequate pain monitoring was the same. There was no difference in nausea and vomiting, and also the opioid treated in total was the same dosage. This is also good news. So to come to my conclusion, I hope I didn't use too much of my time. So what should we do, or how do we do it on our roadway to precision anesthesia? And this is, I think, a very important information also with regard to sedation monitoring, that we should, first of all, do everything like we usually do in regard to monitoring. This does not replace anything. It's just to be considered as an additional item in the fine-tuning and, let's say, augmenting our conventional practice in regard to the sedatives, but also in regard to the analgesics. So don't run slavishly after one value, but always see it in the common context. That was my part.
Very good. Thank you for your presentation. And it's now time for us to move over to the clinical cases. So over to you, Dan, with your case.
Yes. So I hope you see my screen. Congratulations, Professor Radtke. It's an excellent presentation, of course. So the scenario is, let's say, more than 90% real, but I chose to slightly adapt it in order to reinforce the messages that I attempted to convey in my presentation. So this is a 55-year-old male, 66 kilos, 168 centimeters, diagnosed with colorectal cancer, several small hepatic metastases, underwent 8 rounds of chemotherapy, and the echocardiography showed mild left and right ventricular dysfunction with no obvious etiology. The tolerance to effort was difficult to estimate. So the challenges for these patients are to actually provide the intra-op hemodynamic stability, avoid arterial hypotension and low cardiac output, and therefore one of the tools to do this is to individualize the anesthetic drugs requirements concerning opioids and hypnotics, and of course provide the adequate post-op analgesia. So he had a thoracic epidural, which was only activated once the surgery was finished. So at some point in time, actually the patient is hypotensive. So the map is only 63. The stroke volume SC is unchanged. So there's no actually doubt about an eventually alteration of the heart, of the contractility. There's no preload dependency. So this sends us to the issue of eventually low systemic vascular resistance, for which the EEG-based depth of anesthesia monitors are absolutely necessary, so they can say that is the patient overdose or underdose. And this is what the EEG shows. So basically, if you only look at the number, the BIS is show you 44, okay? The EEG is consistent with this, and this is the new display that I mentioned previously, which is a density spectral array. And well, for those of you who are not familiar or very familiar with this, this is the BIS actually trend. But there's probably a doubt into the fact that here at this level, about 8 hertz, the alpha waves are slightly down, and the delta waves. So this is consistent with either desired range 44 or slightly overdose, but it's really very slight. So the induction was with propofol, lidocaine, and sufentanil. The maintenance was with bolus of sufentanil, azathioprine, sevoflurane, and the goal for the BIS was 45 to 60. Now, the patient had received 15 micrograms of sufentanil, which just pharmacologically, this is a predicted effect size concentration of 0.3 nanogram per ml, which is supposed to decrease the hypnotic requirements by about 50 to 60%. And as you can see, I don't know if you see my mouse, the arrow, the normal actually upon the stimulation, which was represented by video laryngoscopy, slightly increased. Now you see there's an instantaneous variation in the trend, but if you actually smooth the data, well, it did increase slightly, not very much, okay? And it decreased actually once the intubation was over. So it did not persist. So the null was, well, actually acceptably low. It slightly went above the 25, which is, we consider the upper limit, which defines a lack of anti-nociception, but it went down spontaneously. So actually what you can say is that if you take a stimulus such as video laryngoscopy, which is not as strong as direct laryngoscopy, well, probably with 15 micrograms of sufentanil, you covered the requirements and you are nearly balanced in nociception, anti-nociception. Now, should I have given a little bit more sufentanil after the intubation? Yes, probably no. Probably no. Why? Because the null went spontaneously down, and I don't know how much will I have to wait before there's incision. So I did not in this case react a posteriori simply because the null went spontaneously down. But you should keep in mind that because the video laryngoscopy is not the most intense nociceptive stimulus, while any conclusion that you can draw from here can only apply to this couple of nociception stimulus, video laryngoscopy, and the amount of sufentanil that you gave. And from the previous actually information that you had, the patient was hypotensive, and that the fact we consider that the BIS value was acceptably in the range, the patient received the baby norepinephrine, baby because it's 10 microgram per ml continuous infusion on the peripheral line. Now, if dozens of minutes later, the nurse calls me and tells me, okay, well, the patient is hypertensive. MAP is 117 millimeters, as you can see here. There's more than 10% increase according to previous value. Option 1, let's say that you're only using the MAP and heart rate as information. You remember that the patient has baby norepinephrine, but it started 20 or 30 minutes before. So you could argue, okay, that the effects of baby norepinephrine should have been earlier. So in this case, maybe the patient is imbalanced and he could actually receive a little bit more opioids. Another option where the patient does not sleep, okay, and in this case, you would increase the delivered concentration of sevoflurane, and you also know that the patient had received sufentanil only 5 micrograms 30 minutes before. Now, if we were face to face and we would vote, I would be convinced that half of you would say, in this case, with what you've told us, we will actually inject a little bit more sufentanil because the last dose of sufentanil was not high and it was 30 minutes ago. Well, the other option is to look at the null, and the null looks like this. Okay, so basically, if you don't have the null, you would actually manage uncertainty by providing a little bit more sufentanil because you're in doubt. Okay, so because the normal values are very low and the surgery is continuing, well, I decided not to provide additional sufentanil. I'm only at 20 micrograms. The last 5 micrograms were 5 minutes before. So I decided based on the null, and you can argue also, do you believe this? And the answer that I provide is yes, I do believe, because now I have nearly 3 years of experience. And this, when you see this kind of tracing, I think you should trust it. So the issue here was the BIS was okay. We decreased the infusion rate of the norepinephrine. So why was it so late? I cannot tell you, but this is the way it was. So overall, this patient actually, this is where I showed you during maintenance, had very, very low requirements. And although the initial part with the intubation, 15 micrograms of sufentanil, video laryngoscopy, you would have predicted that his requirements could be a little bit higher. So the issue is that this is the intra-patient variability. And when you have the null, you don't have to extrapolate from the intubation and induction necessarily to the maintenance. Of course, and once those values that you see here, the patient got extubated and the null becomes difficult to interpret. And what I would like to show you here is that you have basically two actually profiles of null increases, okay? One is slow. It goes slowly up, 2 minutes, 3 minutes before it goes up. Once it goes before 25, when you see this kind of profile, slow profile, I call this, well, then you should worry, and this is probably encoding of nociception. When it simply goes very fast up and it comes down spontaneously, probably you should not take this into account, okay? And this is why you have to keep in mind that some previous information got from the events that preceded what you were seeing are important, and this is why also the pharmacology is also important, as we have already mentioned. So in the context of a patient who is complex, a complex patient will need complex monitoring, okay? So there's no doubt that the null explores the nociception, anti-nociception balance much, much better than heart rate, the MAP, and the EEG. Neither of them is sensitive enough. You could have cortical arousal, but it's not sensitive enough to say that this patient requires more opioids or more anti-nociceptors other than the opioids. And this issue of sensitivity specificity is actually very, very important. And the interpatient variability, I think giving the right patient the right amount, the right dose, is actually something which is absolutely important, and you need to use for this dedicated tools. And if you sophisticate this, I showed you a regimen which is routine, hypnotic, opioid, and MBA, and a little bit of vasoconstrictor. You can sophisticate with opioid sparing or opioid-free anesthesia, and in this case, you really need to know what is going on and whether the nociception and anti-nociception are balanced. Once again, thank you very much for your attention. And so the more complex the patient is, the higher the probability of dissociation between the parameters. And the more complex the surgery is, the more complex the patient is, the higher is the probability that with only one parameter, MAP and heart rate, that's out of debate, it should not exist anymore. EEG is helpful, but is not sufficient to be very precise and to personalize anesthesia. And thank you very much for your attention. I stop sharing my screen.
Thank you, Dan. Finn, any comments to Dan on this case?
Well, as always, fantastic talk. And it's I liked everything, but I especially like the conclusion, which I would absolutely put my signature on, that that there's not one, well, of course I'm exaggerating a little bit, but almost not one anesthesia where you don't get surprised or where you modify through EEG monitoring or nociceptive monitoring your usual way of doing things. And that is might be a challenge in the beginning of your career when you already are exhausted by the normal parameters. But on the other hand, it is so rewarding when you finally get a little bit more insight and not just guessing what kind of how to administer and how to dose your two main how to dose your two main substances.
I fully agree, Finn, and I think that what I presented was actually a patient who was at risk of hemodynamic instability. So those you would consider the patient as complex. Now, if we take your approach, in which post-op outcome is as essential as intra-op hemodynamic stability and avoidance of cardiovascular complications, and in this case, there should be no patient who would undergo surgery, even herniorrhaphy or simple intervention, for which we should consider that the patient will not require monitoring, because you can actually, even in simple surgeries, you can actually get wrong and manage uncertainty by overdosing opiates. And since we have remifentanil, and when I was a young resident with the fentanyl, if you gave too much fentanyl, the sanction was immediate at the end of surgery. The patients could not be extubated.
Right.
With remifentanil, you actually manage the intra-op and you will have problems in the PACU.
Yeah.
Okay. And this is where just providing as much remifentanil as you would like without monitoring, I think it's important. So basically, we say that patients who would benefit most would be those who are complex, for complex surgery. But in fact, I think that all patients, if you look at outcome the way you do, and I think this is the way we should look at outcome, all patients would actually deserve such a kind of monitoring.
Yeah. And what the interesting thing is, Dan, lately, and this is kind of how we change over time, I would almost, before I shouldn't draw any conclusions here, but how we change over time is that now I start to feel embarrassed if I hear that any of my patients had nausea or too high pain in the recovery room. And this is something that in the early years of my anesthesia practice hasn't really been greatly honored by myself. Now I think the change of responsibility changes. Okay, and a lot of things you showed you will rediscover in my film. This is what we call the SBI video clinical immersion here. And this is the first video actually where we try, or where we capture on 8 GoPros and 2 mobile cameras what actually happens intraoperatively. And these are not selected cases. This is a random case. Of course, we had a little bit of preparation, but there was no special reason why we chose this case. And I'm a bystander and help a little bit. So you see the whole, the reality reflected in this film. And the patient his name is Werner. And he was scheduled for lumbar laminectomy L3, L5. He received a TIVA, propofol, remifentanil. So I scroll through it. So this is Werner. He's 82 years old, body mass index 29. He has 2 units of alcohol each day. I would personally think that he has more, but that's what he said. None other specialties. Diagnostic, he has a spinal stenosis in his anamnesis. Arthritis, osteoarthritis, and has had a prior diverticulitis. It's the whole thing that the story gave. As pre-existing medication, he has pantoprazole, not 44, I'm assuming it's 40 milligram, Cox hammer, and he has a daily dose of oxycodone, which is of relevance, especially to this case, of 20 milligrams. So he is a user of opioid medication. So let me go through. This is our preoperative check. So let me scroll a little further. There we go. All our patients are screened, so we have a very clear baseline. Where do we start with this patient? And we repeat this. I will show you later at the end how is the turnout in this patient. So Werner has a RAS of +1. He was a little bit edgy and moving around. He has a NUDESC value. You know, NUDESC goes from 0 to 10 of 1 point, which is under the delirium threshold. Months of the years backwards, he could not do. He started, but he had to interrupt. That's why he got 1 point there. His pain level in rest and under movement was 7 for both. He has 0 on the nausea scale from 0 to 10, no nausea. Anxiety, stress is 0, so not anxious, no stress. And his general well-being from 0 to 10, 10 is the best. He gave us a 10. So then this is right before our OR. So we drove him into the OR. And down again, I'm going to scroll through this. There we do all the prep things, then we start entering the split screen. Obviously, it's in prone position, so there's some preparatory work. Yeah, nurses, a colleague of mine, there he gets the EEG monitoring. Also in prone position, you can use EEG monitoring, as most of you probably know. Here we go a little bit further. Now you see the 5-fold split screen. And he is ready. You still see a lot of artifacts on the EEG monitoring, also on the node monitoring. You notice his blood pressure. So he is hypertensive, might be due to the situation. So 80 MAP, this is of notice. Then we have a junior doctor starting with the pre-oxygenation. And my colleagues at the end, and you can see the cameras on the different screens back there also. So they start, and you can see still a lot of artifacts. And here we go now. We have the EEG and the base value on the left lower side. We will be seeing the null value on the right side. And there's a unique thing in Denmark, at least in the area of Region Zealand, is that relaxant-free intubation is very much favored by many. I'm absolutely against it, but this is what a lot of colleagues do, and this is what they choose to do in this case. So you will see they started with propofol and remifentanil, and there's also a unique thing in milliliter per hour. That's what they like to calculate. This amounts to kind of 0.7 in micrograms per kilogram per minute for the Ultiva, and for 7 for the 0.7 milligrams to in the propofol range. So this is kind of the standard dosing, nothing special about that one. They pre-oxygenate. You see how there's still a lot of artifacts on the EMG and on the BIS monitoring, and then you see how we start with the propofol. You cannot see any effect on the EEG, and then you see at this point that they administer a bolus of 140 milligrams. There we have the null value. And then you can see, this is the first case where they aim to intubate. Then we have to go to minute 4:41. And there you can see they intubate with the video laryngoscope. There we go. And you can see that while they try to intubate, let's see it here. That they intubate, here we go, that they cannot intubate because the vocal cords are closed. This value is in range, excuse me, this value is in range. This value is in range. There we have to go a little bit backwards again. But they could not intubate, so they had to do another attempt. This is at 5 minutes and 18. You can see, yep, that they, here you can see that where the vocal cords are closed. In the left upper corner, you can see the McGrath where the vocal cords are closed. Obviously, not a good idea not to use muscle relaxants. Under the intubation, you have a little increase, a very slight increase in the null value in the middle lower corner, but under no circumstance would I say here we have insufficient analgesic management. So they do another trend. This time, then they give rocuronium 20 milligrams at 5:18, and there you can see then finally, after the third attempt, there we go. No, they can see that they have a successful intubation at that point. Where are we now? There we go. Yeah. There the intubate, you can see the opening, and this looks much better, of course, after muscle relaxants. It's good done. That's a specialty in Denmark, and it's not very, in my eyes, not very professional, but that's how they like to do things. Okay, then we move on to then of course he's turned into prone position. And then the next episode is when and I'm speeding you a little bit through this, but otherwise we had to have 20 minutes. Then you see how they prepare everything. Null value, this value is pretty much in range. In between, the blood pressure drops a little, and then give phenylephrine 10 milligrams to stabilize. But otherwise, most is smooth sailing until we enter the incision part. this is where we go here. This is kind of interesting because it kind of proves the point. You have a prepare, look at the null values, they kind of are, there's a little bit noise there, but you see at the point when they start with the surgical procedure, you get a quite impressive, and certainly over 1 minute lasting bump in the null values. Let me go back to 901, and this is kind of this area. So, and what is interesting about that one, that while you have an increase in the null under the incision, the question is, what is it again noise because it's not kind of that obvious, or, and it goes actually up to 59 over some seconds. And what is a huge benefit in this case is that you have also the DSA at the same time. When you have the opportunity, when you have the opportunity to look at both parameters, while you have the bump, the prolonged period under the incision of above 25, and this was covering more than 1 minute, plus you can see in the DSA a little bit later that there's a loss in the alpha power of the DSA. You know that this is very much in accordance to too high nociceptive stimuli that at the same time also makes the alpha spindle disappear in the DSA. And in this case, this of course is a question to Dan Longrois. In this case, I think it's very much because both are aligned. First of all, I would react on the null by itself, but this again gives you reconfirmance that there's most likely a benefit by giving additional pain medication. In this case, they gave 10 milligrams of oxycodone, and this kind of also solved the problem over time. Good. And the other part is what you see on the BIS monitor again, is that you have a suppression time as well as in this case a suppression ratio. So you have a tendency a too deep anesthesia. And in this case, I would if it would have been my anesthesia, I would have increased due to the null monitoring and the loss of the alpha spindle power. I would have increased the opioid concentration and would have decreased by that the hypnotic concentration to optimize in both areas let's say the personalized need of this patient. How am I doing on time, Rachel?
We're actually a little over time, Finn, so it would be good if you could summarize and then offer Dan an opportunity to comment. Yeah, so in order to kind of, and of course I could keep showing that, let's move to the end of the, so how did the patient do post-operatively? And here we put it together. So when he arrived, pre-operative, he had a RAS of 1. He had the same RAS when he arrived in the PACU, and also had a discharge. So he's just in general let's say a nervous or a hyperactive person, if you want to call it that. In regard to the other parameters, you can see also the very typical. There we go. The typical NUDES value, right arrival to the recovery, we had an increase, and this might be still an effect either because he's vulnerable or because we could have even more optimized his anesthesia, but he came down prior to discharge from the PAC back to his normal value. He could not do at all the months of the year backwards up on arrival to the recovery, which I usually like my patients to be able to do, but he could do it at the discharge point. His pain changed from 7.7 before to 6.6 upon arrival and 2.4 prior to discharge. And the same with the nausea, no nausea at any time. Anxiety, stress was not a problem either, and his well-being took a little dip upon arrival, but increased to 10. So in all, we were pretty happy with how things did. Always we could have a little bit better fine-tuning nevertheless, but we were not unsatisfied. Okay. Thank you, Finn. Dan, over to you.
Yes, Finn, you and your team should be congratulated for this absolutely huge effort to put all this into a video, and I think it would have required half an hour because it was beautiful. I have a question to you. First, of course, you have champions in your team who are interested by this. What about the other members? I mean, is everybody in the team, nurses, anesthesia nurses, and physicians and residents, familiar with all this, or is it for the moment dedicated to champions?
Well, you always need somebody who's driving whatever you do, somebody needs to drive the initiative. And then there's, let's say, these 60-70% that follow because they think it's interesting. Then there may be 20% that need a little bit more convincing, and maybe 10% that you never really reach. That's at least my experience. But what I really like about nurses and physicians in general is that you still have most of them. You can activate the interest. We're all in there to help our patient. And this is a very good thing to know, that your own colleagues and your own staff can be activated to do that. And quite to extend that, even by presenting them how their patients are doing, you seem to doing it, they're really, well, they're much more satisfied because they suddenly know, okay, it makes a difference what I do in regard to the treatment of patients. And then you get the evaluations of the patients to the single nurse and doctor saying that, oh, they were happy in average, or they were not happy. So you have really an opportunity to make a difference there. So this has been has received a very warm reception from most of my colleagues, and some, of course, they let's say they were less enthusiastic.
I think you're right to put immediate and middle-term post-op outcome into the balance, because it's not just fencing with monitors, it's also patient-related outcome, and this is very important. I had a question from Zev Golding that I answered, but I would like to address, because it's a message somehow to the manufacturers, including Rachel. So you've seen in real time the way we should actually have our eyes change from one monitor to another. And Zev said, is there going to be one day an integrated number that will put together null and the BIS? And I answered in text, in my mind, there shouldn't be, because the interpretation of the signals, as you've nicely shown, is such that it requires their physician and nurse intervention so that one recognizes and interprets the raw tracings. So what is needed is a single screen, probably bigger screen than what we have, where you avoid moving from one screen to another. So putting screens together, okay, so integration over the monitoring, but not integration of the numbers and the signals, because they require too much interpretation. Do you agree with that?
I think then that's very well put. I would almost, let's say, I support what you said. I personally like, and this is maybe my own special, I like to have it on separate monitors, very closely aligned, which is probably the same as one big monitor. So I can move, how am I doing on sedation? How am I doing on analgesics? How is the hemodynamic? So I always have my routine where I kind of go through. And I think that is maybe just my own routine, how I do it. But bigger monitor, absolutely, but not at the cost of having less information. Because that is putting it in one number, and you are so right about that one. Putting it in one number would simplify things, and that is one thing that I'm absolutely not interested in. I like the complexity of information, because this is all extra information, and it doesn't distract me from my routine care. Just to absorb the information and then make my decisions on a little bit more background than in the old days.
Just a final short comment. We didn't really actually attempt with Finn to provide you a unique message. So this is the two messages which are fully concordant based on our personal experiences and, of course, the literature, and convincing evidence that we need to look separately with separate instruments and separate monitors at hemodynamics, EEG, and nociception, anti-nociception balance. And we showed you the discordances and at times the surprises. And this is the way we reduce uncertainty. And I think there's no other way around to reduce uncertainty.
Yeah.
Thank you both.
That makes our job also interesting, we have to say, no?
Of course.
Okay, well, this has been fascinating. Thank you to our speakers. Professor Dan Longrois and Dr. Finn Radtke, and we look forward to seeing you at future events. And if you have any questions that come up and you haven't yet had the opportunity to present them during the webinar, please don't hesitate to reach out to us. We can also reach out to our speakers or try to answer yourselves too. And we appreciate the collaboration and look forward to continuing our engagement with the clinical community. So,
Rachel, sorry, there was one question on methadone, whether the data methadone and null. To my knowledge, no, but it shouldn't matter because it encodes an imbalance between nociception and anti-nociception. It may very well be for the lower value of null drug specific, but in general, it should be physiology and pathophysiology specific more than drug specific.
Yes, I would tend to agree, but absolutely looking forward to the researchers who are going to do some studies with null and methadone. We look forward to hearing the results.
Great.
So,
Fantastic.
thank you again, everybody, and we appreciate your engagement, and we look forward to remaining in contact. Thanks, everybody.
Goodbye.
And, see you on our next event. Goodbye.
Goodbye. Thank you.
Bye-bye.
Thank you, Rachel.
Thank you.
Thank you, Joanne.
Thank you.